apologies for the technical glitch. I look forward to an engaging discussion where we will be discussing tonight the gastric biopsy, where we're trying to make sense of the pathology report, and where appropriate, we'll be looking at the clinical implications of that report. I'd like to also welcome everyone who is here in this meeting. So this will be the outline of my presentation. I will not go into detail onto that, so you'll just appreciate it as we go through the presentation. Just to confirm that you can hear me clearly, you can just put a thumbs up on the chat, then I will know. Okay, thank you. I do not have any conflicts of interest for this presentation. I am not paid to do the presentation, but I am an employee of AMPAT, Pathology Laboratories. As Dr. Pillay has indicated, I'm based in the Pietermaritzburg office. So with regard to the gastric biopsy, it is one of the most common biopsies that as a general pathologist get to see. And through that, that means that every doctor will generally be encountering a gastric pathology report. And it is important that when one encounters such a report, is able to understand what it means, what are the implications, what are the next steps to take once you have the report, and then advise your patient appropriately. With regards to the biopsy techniques as well as the reporting guidelines, there has been much changes, especially when it comes to the reporting guidelines, although those changes are not yet fully implemented or accepted worldwide. But with regards to the biopsies, really nothing much has changed. The guidelines still advocate that 5 biopsies should be taken, one from the lesser curvature and parts of the antrum, one from the greater curvature, part of the antrum as well, 2 from the corpus, lesser curvature and greater curvature, and the insula angularis. The rationale essentially behind that recommendation is because the gastric pathology tends to be unevenly distributed. So when the biopsies are actually, we are not taking adequate biopsies, that means one can miss the diagnosis or can miss the pathology because other parts of the specimen are not represented. So with that as well, when it comes to the reporting guidelines, whether one is looking at the Sydney classification system, the Olga system, or the Olkim assessment system, these also use these 5 biopsies to actually create the various components that one may be seeing in the specimen, whether it is the activity, the severity of the Helicobacter pylori infection, the atrophy, the intestinal metaplasia, the activity that is present. So, which means that whenever the specimen is submitted, but we don't have that number of biopsies, although we may give the grade or the scores as per the guidelines, but that is not essentially as accurate, because for the recommendations, we're supposed to be following these particular biopsy guidelines. And also important that with that biopsies, we have a clear indication of the exact site of the biopsy, because various diseases will occur at various sites of the specimen. In addition to that, in some instances, you may find that the body may change and look like the antrum on microscopy due to the disease process. So if you are not aware of the biopsy site, there may be challenges to give that interpretation accurately. So with regard to the Sydney classification, which has been updated several times, what we largely look at, we grade the degree of the Helicobacter pylori infection, which is the mycobacterium that we commonly see in the stomach. We grade the degree of atrophy in both the stomach and the corpus. We grade the level of disease activity by activity that is defined by the presence of neutrophils in the lamina propria, as well as in the crypts, and in the epithelium. So it doesn't matter where those neutrophils are occurring, as long as we are seeing them there, then that will constitute activity. And then the chronicity is defined by the presence of the mononuclear inflammatory cells, which those will be the lymphocytes, the plasma cells. You can even have histiocytes as well. Whilst the atrophy is defined by two components, either of is adequate, where you have the loss of the specialized glands, which that will predominantly be in the corpus body, or the presence of intestinal metaplasia. So those will define the degree of activity. And then those will be graded from 0 when it is normal to mild, moderate, and severe, depending on the degree of the involvement. The operative link on gastritis assessment. This is a system that was introduced in the early 2000s. But at the time has been more research that has been going on with these reporting systems. What this system essentially does, it assesses the extent of gastric atrophy in an attempt to actually classify the patient into risk categories for the possibility of developing a gastric cancer. So in other countries where there is a high prevalence of gastric adenocarcinoma, so this system is used as a means to actually grade the patient who are more likely to progress to an invasive carcinoma of the stomach, so that they are being followed up more or less in a similar manner to patients who are having a Barrett's esophagus. So the idea is that the tumor can be picked up fairly early if these patients are being followed up, and then have an early diagnosis. So, for example, patients who are regarded as a stage 3 and a stage 4 are put into the high risk category, which they say they warrant a follow-up, endoscopy, and biopsies. However, this is an evolving algorithm, so we may expect changes to happen as time goes by, as it is more better understood. So there are some studies that are continuing. However, in Asia and in Europe, and to some extent in America as well, this is already being practiced. The other algorithm also assessing for the risk of cancer is the operative link on gastric intestinal metaplasia. So with this one, what one looks at, it looks at the extent of intestinal metaplasia. So it will look at the extent of intestinal metaplasia in the corpus, also in the antrum. In terms of its grading, like moderate, mild, moderate, and severe, this is just an extrapolation from the Sydney classification system. Then it goes on to be graded. So this presentation today is not necessarily for us to actually go through and investigate or critique this system. It's just to actually introduce this. I think if there is more interest on this, we may have to relook at it at another time. So again, with the Olgim system, patients who are graded as a stage 3 and a stage 4 are regarded as having a higher risk of developing a gastric adenocarcinoma, which they also warrant follow-up, as well as subsequent gastroscopies and biopsies to assess for the risk of gastric cancer. As far as I'm aware, through my chats with some of my colleagues here, we are not yet using this particular system in our reporting in the country, and I'm not also using it in my daily practice. And I don't think any of my surgeons have asked me to actually use it. But it's something that it is important for us as pathologists as well as doctors to be aware of and familiarize ourselves with it. I think one of the challenges, especially with our country, is that our cancer registry program is not as accurate. So we probably not even able to say whether are we as a country which has a high prevalence of gastric cancer. So then in that way, can we justify using this system? Number two, will it be justifiable for our patients to also have these subsequent scopes? However, we do report if there is a dysplasia, of course, in our patients. We did report the presence of atrophy. So it's just that we are not doing this grading. However, we are reporting, which potentially with the appropriate specimen, one would always be able to extrapolate and include this type of information. I think I will just touch briefly on this. Most of us have gone through this, whether it is an undergraduate program or postgraduate program, where we discuss the pathogenesis of Helicobacter pylori associated gastritis, which this is actually a bacteria that would proliferate in the stomach, and its pathogenicity is through its having the gene urease and the flagella, which allows it to attach to the mucosal cells, and the toxin that it also produces. So these mechanisms allows it to actually cause a tissue injury, which and also modify the toxic environment within the stomach so that the bacteria can actually survive. And currently, Helicobacter pylori is actually regarded as a carcinogenic microorganism in a similar extent as a herpes simplex virus 8, human herpes virus 8, Epstein-Barr virus. So these are actually carcinogenic microorganisms, which it is important that whenever the patient is having Helicobacter pylori infection, as a clinician, you make sure you institute eradication therapy so that these patients don't later on go on develop the cancer, and then you are being blamed for not actually having treated them appropriately for this carcinogenic microorganism. So I think even without trying to scare us as a doctors, I think with the awareness that the lawyers are always trying to look for ways to sue us and get money out of us. Another person may say, oh, this patient had a gastric biopsy X number of years ago, and then there was Helicobacter pylori, it was not treated, suddenly this patient is having cancer. So because we have not treated, we are now liable. That is something that may be possible, you know. I'm not sure if there are such scenarios, but we just have to guard and make sure when we have these reports, we are instituting the appropriate treatment. And in some countries, they actually recommend that after the eradication therapy, the patient will get another biopsy to actually confirm that the treatment has worked and the Helicobacter pylori has been cleared. So with regard to the chronic gastritis, this is one of the most common diagnoses that we make with regard to the gastric biopsies. When we get this report, mostly one will see a report goes like chronic superficial gastritis or non-specific gastritis. And of course, usually in this type of a report, these are reports where we are not having specific infective organisms, or we are having the H. pylori. However, in other instances, as in the stomach, there are a lot of disease processes that we can get. For example, you can get HIV-related infections in the stomach, whether it is your cytomegalovirus, whether it is your cytomegalovirus, whether it is your PJ your PJP organisms, which you can get. But for this charts, for this presentation, the aim was not to look at the HIV-related pathology in the stomach. So I have completely left those ones out. So just going to look at chronic gastritis, which is the more common diagnosis. So how I look at it is to see where is actually the inflammation. Is the inflammation involving the superficial parts of the gastric mucosa? So remember, the gastric mucosa comprise the alveolar cells, then your specialized glands, then the muscularis mucosa, which actually, then after muscularis mucosa, then you get the submucosa. So is the inflammation involving the superficial parts of the mucosa? Is it involving the bottom parts of the mucosa, or is it a diffuse involvement of the mucosa? That is very helpful in terms of deciding what is the possible cause of your gastritis. And also importantly, is it involving like the body of the stomach, like the corpus, or is it involving the antrum? Because the diseases tend to involve different areas, with the H. pylori predominantly involving the antral parts of the stomach and having a superficial distribution of the inflammatory cells. So when one sees that is the most likely diagnosis, the Helicobacter pylori. In some instances, one can get Helicobacter helmani, which is a very rare component, accounting for less than 1% of these organisms. So, but we are able to see these as morphological, they look different from each other. With regard to the bottom heavy inflammation, so the main considerations include the autoimmune metaplastic atrophic gastritis, autoimmune pangastritis, and autoimmune enteropathy, which would be, although it's predominantly a small bowel disease, but it can also involve the stomach. We're just going to delve into these a little bit further. So with regards to the top-heavy chronic gastritis, as I indicated, these are predominantly related to the Helicobacter pylori infect organisms. You can see when you look at this section, this is a hematoxylin section. This is the top part. So this is the lumen of the stomach. This is the surface epithelium. This is the muscularis mucosa. These are the specialized glands. So where you have this blue appearance here, that's where you have actually predominance of the mononuclear inflammatory cells, your lymphocytes, your plasma cells. And this part here, we are having this area that shows the dark staining. So this is actually the mental zone of the lymphoid aggregates. And then at this center is a germinal center that is reactive. So it shows polarization. So when you see this pattern and you see these reactive germinal centers, this is kind of like pathognomic of Helicobacter pylori infection. If one has this biopsy, I'm not seeing the H. pylori on my H&E sections and my special stains, I will proceed and do the immunohistochemistry stain, which we actually have here at AMPATH, and see if I can find the organism. And if I don't find organism in this particular specimen, I will have to reconsider why am I not seeing organisms and give other possible reasons. And one may have to check the clinical history of what may be the underlying causes. We will just catch that shortly in the subsequent slides. So in the context of top-heavy chronic gastritis, one can see in this slide, you have these bacilli, which are actually the Helicobacter pylori within the crypt. And then in this lamina propria here, you can see the mononuclear lymphocytes and plasma cells. So this will be part of the Helicobacter associated gastritis. So we don't always do the Helicobacter pylori immunoperoxide stain. These largely because these are actually expensive tests. But whenever one doesn't see the organisms and the reaction pattern is appropriate, I know I'm supposed to be finding these organisms. I will then proceed and do this particular stain, which is actually very beautiful. It just brings out these spiral-shaped bacilli within the crypts in the surface as well. So the thing about this stain is that it also cross-reacts with the Helicobacter helmani. So we cannot use to distinguish between Helicobacter pylori and Helmini, because they will both stain with this particular stain. But it will identify the organism. One of the things with the Helmini is that it will show less inflammatory response relative to the Helicobacter pylori. But it's a very useful adjunct if one is to actually make sure that we are not missing these particular organisms and we are able to make the right diagnosis, especially in the right context. But it shouldn't be a stain that is done on every biopsy. So why is it important to make this particular diagnosis, and what should we look out for in terms of clinical implications? So if we are not making this diagnosis, for example, the disease process may continue, it may lead to ulceration, or it may progress to atrophic gastritis. In this context, it's referred to as the H. pylori associated atrophic gastritis, also referred to as environmental metaplastic atrophic gastritis. This patient would be at an increased risk of developing the gastric cancer later on after they have progressed to the metaplastic atrophic gastritis. There's also a risk of these patients actually down the line developing a mucosa-associated lymphoid tissue lymphoma, so-called Moll's lymphoma. So making this diagnosis and treating this Helicobacter pylori and eradicating it essentially means that you are minimizing to eliminating the possibilities of these complications arising later on for your patient. Top-heavy chronic active gastritis. So when we see top-heavy chronic active gastritis, however, we are not finding Helicobacter pylori organisms. After having done the special stains, those can be either a Warthin-Starr stain or a Gimsa stain or a modified Tolden blue stain. And we also proceed and we do the Helicobacter pylori immunoperoxidase stain, and we still don't find microorganisms or the bacteria. Then what could be the other possibilities to explain the presence of chronic active gastritis? So it might be that the patient has actually had eradication therapy, and the resolution within the stomach mucosa is just taking longer or is lagging behind. Or it could be that the patient is has received proton pump inhibitor therapy. In these instances, with proton pump inhibitor therapy, the morphology of the bacilli actually changes. They become more coccoid in their appearance, so meaning that one is likely to miss them or maybe even call them something else. The other possibility is to consider an inflammatory bowel disease. It is more likely in that instance to be Crohn's disease as opposed to ulcerative colitis. Ulcerative colitis really involves the stomach. And in terms of the appearance in this particular instance, one will see gastritis, so there will be chronic inflammation. Mostly in these instances, it tends to involve the entire thickness. You have micro abscesses, so we have a neutrophils within the crypts of the bowel, and you also have a cryptitis as well. Neutrophils infiltrating the intraepithelial neutrophils. So with that type of activity, generally you will find your H. pylori. If your H. pylori is not there, you may check with the clinician who's actually sent the specimen if the patient is actually having other symptoms that may suggest inflammatory bowel disease. In about a third of patients, you may find granulomas as well, but due to sampling errors, those are not always identified on the small biopsies. But in this instance, Crohn's disease should be considered as a possible underlying cause for the gastritis in this particular patient. Some histiocytes may be present in the lamina propria as well. However, it is important that you make sure that you first rule out your Helicobacter pylori infection. We can also look out for any other infective organisms that may occur in the stomach, whether it is your CMV, etc. But CMV generally will have a more lymphocyte-rich inflammatory response with less neutrophils, unless there are other complications like ulceration or ischemic changes that are also taking place. So we move to the bottom-heavy chronic gastritis. So with a bottom-heavy chronic gastritis, the consideration in that pattern include autoimmune metaplastic atrophic gastritis. Importantly, the autoimmune metaplastic atrophic gastritis, the disease predisposition is largely in the gastric body corpus area. So it is important that the biopsy is labeled appropriately. It makes life easy for us in the lab, but also for the interpretation of the findings. I will be going more into details on that. The other finding with bottom-heavy gastritis is autoimmune pangastritis. So with autoimmune pangastritis, in this context, the entire stomach is actually involved. The body, the corpus, the cardia, the antrum, there is just involvement of the entire stomach. And last but not least, the autoimmune enteropathy. We will just get into this in small details later on. So the autoimmune metaplastic atrophic gastritis, this largely seen in the elderly women, will be associated with vitamin B12 deficiency, so leading to the pernicious anemia. These patients may also present with iron deficiency anemia. This is due to the decreased iron absorption in the stomach. They also have an increased risk of gastric cancer. So the cancers will include adenocarcinoma as well as neuroendocrine tumors, but the neuroendocrine tumors are actually indolent neuroendocrine tumors. So as you can see that this patient is also having iron deficiency anemia, pernicious anemia. These patients may also be complaining of fatigue and other symptoms that are related to anemia, in addition to having, for example, epigastric pain, for example, or dyspepsia. So like I said earlier, it's important to indicate the size of the biopsy. So in terms of the histology findings in these particular patients, you'll find the inflammation predominantly involving the lower parts of the mucosa. As you can see in this specimen, we have predominantly inflammation just above the muscularis mucosa. Then the top part is less involved. What you also see is that you have these Punnett cell metaplasia and the goblet cells, which is part of the intestinal metaplasia, part of the atrophy as well. And then one will also appreciate that when you look in some of these areas, the specialized glands actually are missing in this in these areas. And this being the body of the stomach, you expect to have a lot of specialized glands or parietal cells or chief cells, but these are actually disappearing in these particular patients. And essentially, it may start looking like we are looking at an antral biopsy. So when you tell us, actually, we have this biopsy is from the body, it also allows us to make that call with confidence without having to do a lot of other investigations, which may also be expensive for an individual patient to then reach a diagnosis. One will still do the Helicobacter pylori stains here, which you expect them to come back negative. So this is just another appearance. showing this deep-seated inflammation. As you can see, lots of these lymphoid aggregates, predominantly at the base, areas of atrophy that we can see with the loss of the glands. So the disease process is also patchy in this particular specimen. What is actually very helpful in these patients is that when you do neuroendocrine markers, that would be your synaptophysin, chromogranin, you will find that there is a neuroendocrine cell hyperplasia, enterochromaffin-like cell that actually increased. So normally, when you do these stains, they're supposed to stain single cells, you know, and not be making these linear patterns or forming nest-like patterns, as you can see here. So this is a feature of hyperplasia. And if one is not familiar with the pattern, there are a lot of images to compare with what actually a normal appearance will be like. So these are also become the precursors for the neuroendocrine tumors in these patients. So they may develop carcinoid tumors later on as well. And then this is also helpful for diagnostic purposes because this neuroendocrine hyperplasia tend not to occur in the autoimmune pangastritis. So when you see that, it kind of like take you away from the autoimmune pangastritis as a diagnostic consideration if you don't have a full set of biopsies available for assessment. So the clinical implications for these patients when we make this diagnosis is that these patients essentially we are saying that they have pernicious anemia, so they are having issues with producing antibodies that will target your antiparietal cells and your intrinsic factor as well. So then one can proceed and do the serology investigations for that, which should be able to confirm that. And then these patients have an increased risk of gastric cancer, as we have alluded earlier. And I think it also helps for you as a doctor when you are investigating your patient for this iron deficiency anemia that you are not sure what it is when you do your gastric biopsy and suddenly you can get these results and then it is able to bring it out to you that this is actually the underlying cause. Autoimmune pangastritis. Autoimmune pangastritis is a rare disease. There are not many articles published on this entity. However, there was a case series in the American Journal of Surgery. I think it was in the around 2006 or so. So where they described these patients as having a gastritis involving the antrum and the body, and also showing this bottom-heavy pattern. What was interesting with this patient was that all these patients had systemic autoimmune disease that they had. And these patients, on their serological investigations, were negative for antiparietal cell and anti-intrinsic factor antibodies. So the hypothesis was that it means for these patients, there is an autoimmune process that is targeting more cells within their gastric mucosa, and this is targeting the entire part of the stomach. To date, there is no clear defined like pathogenesis for the autoimmune pangastritis. But it's something that I think we should be aware and be looking out for, and it would help us again when we have those biopsies that demonstrate that we know that we have the body, the antrum, so we know where all our biopsies are coming from, that we can actually be able to make such a call, and of course having the appropriate clinical history. In terms of the age distribution, it is very wide, from young children to elderly patients. So we cannot use that information. It could affect anyone, essentially. But what's fine in this patient that you have this pangastritis, that is just diffuse involvement involving all parts of the stomach, from your antrum to your body and your cardia. And in this instance, there is no neuroendocrine cell hyperplasia. So the compensatory mechanism for the loss of the cells is not even taking place. So that becomes a very helpful ancillary test when you do the synaptophysin and chromogranin to differentiate as well between the autoimmune metaplastic atrophic gastritis. So with autoimmune pangastritis, especially for us as pathologists, we may see a lot of apoptotic bodies within the surface mucosa. So that pattern kind of like mimics a graft versus host disease. So when you have the appropriate clinical history, you can make the correct information, you can interpret that appropriately. Because in this instance, the patient shouldn't have had a history of transplant, for example. Your neuroendocrine markers will show that there is no neuroendocrine cell hyperplasia. The cancer risk currently is uncertain. I think this is largely a function of there are not so many cases that have been reported. There is a high association with systemic autoimmune disease, as I've listed some of the autoimmune disease that may occur in these patients. So in this context, if we are to make such a diagnosis, then it becomes imperative for the clinician as well to take more clinical history and look if there is any specific autoimmune disease, or even do additional investigations to try and identify any underlying autoimmune disease. Autoimmune enteropathy. This is a disease largely of the small bowel. However, it has a similar histological findings with the autoimmune pangastritis and even autoimmune metaplastic atrophic gastritis. However, the clinical presentation would also be different, whereby these patients, they generally present with intractable diarrhea. So in these patients, I think if, let's say, the gastroenterologist or the surgeon is taking the biopsy of the stomach, most probably also take the colon as well. But if your history, for example, is like diarrhea, and then you see the severe diarrhea, you see the pattern that looks like autoimmune pangastritis or AMAG, then one may have to put this into the consideration as the possible etiology. What is even more important with these patients is that these patients tend to have an associated immune dysfunction, or may have a polyendocrinopathy or enteropathy and X-linked inheritance diseases. While some may have autoimmune polyendocrinopathic candidiasis or ectodermal dysplasia. So for them, the treatment essentially is a immunosuppressive therapy, which would be biologicals and nutritional support. They do best with this kind of treatment. So the approach may be different, but it is important to be able to identify the morphology and put it there as a differential consideration in the right context. Again, emphasizing the importance of having the appropriate clinical history and clinical context when we get the biopsies. We're gonna now move to other lesions that we may see, like the reactive or chemical gastropathy. So with these specimens, they tend to have minimal inflammation. And what is important on our side, especially in the lab, is to make sure that we are not overcalling, because the cells may look atypical, mimicking dysplasia. And the clinical history here is important if the patient has been on NSAIDs at least in the last 2 months, or any drug the patient has been taking in the last 2 months should be on the form. It will help us for our interpretation. The other causes may be part of a bile reflux. So if there's been a procedure like Whipple, then it may help us to also know. It may be part and parcel of autoimmune metaplastic atrophic gastritis, or it may be seen as part of gastric enteral vascular ectasia, which may show areas of fibrin thrombi in the blood vessels. It may also be seen as part of portal hypertensive vasculopathy. Again, the appropriate clinical history is important for us to make such a diagnosis, because the findings are just non-specific, so they can mimic several things. So with reactive or chemical gastropathy, so one of the findings, one will get the loss of the surface mucin, the foveolar glands. They tend to have this corkscrew appearance, as you can see there. There is minimal inflammation in the background. You get congested ectatic blood vessels, minimal activity, minimal inflammation, unless there is overlapping disease, for example, with H. pylori infection or other infection, then you may have overlapping features. But if it's just pure reactive gastropathy, this is more of a typical pattern that one will be seeing, and then we have those consideration as the possible causes, and the clinical history will then be helpful to clinch the underlying cause. So when you have the right clinical context, then it will help us to actually not make an overcall and diagnose the dysplasia when there is no dysplasia. We look out for the presence of, if it's due to GAVE, for example, we identify the fibrin, but also the clinical history where the clinician may say that has seen a watermelon stomach. Then that helps us to also quickly make that diagnosis. Then we can move to the next patient and help the next patient as well. So in GAVE, these patients are at risk of gastric bleeding and anemia, similar to patient with a portal hypertension developing a reactive gastropathy. So also taking us to the importance of the judicious use of drugs. So I think at some point, whether during an internship or community service, one has come across with, for example, almost every patient being given, whether your iron supplements, your multivitamins, might be your vitamin A's, might be your iron, vitamin C, whatsoever, And it is important that when we issue these drugs, we are always aware that they are not so innocent. Even the Panado is not so innocent, not applicable in the current presentation. But I think as a pathologist, sometimes we see those rare instances where somebody is actually developing liver failure secondary to Panado, or you get somebody developing gastric ulcer, perforation because of iron therapy. So we have to always be wary that will this drug or tablet be beneficial to the patient, and if not, not issue it. So gastritis with prominent eosinophils. There's a terminology of eosinophilic gastritis. I think it's important that as a pathologist and clinicians be wary of that terminology, but use it in the appropriate context. And the prominence of eosinophils in the stomach does not always equal to eosinophilic gastritis. We need to always make sure that we identify the underlying cause for the eosinophilia in the stomach. And the diagnosis of eosinophilic gastritis is a diagnosis of exclusion. So before we make that diagnosis, we have to make sure that we exclude other possible causes for the eosinophils. So the approach that we looked at, top heavy, bottom heavy, is still very much applies in this particular instance. And if it shows a top-heavy pattern, it could still be related to Helicobacter pylori. Actually, I think this or last week, late last week, we had a case in our department where we had a gastric biopsy with a massive eosinophilia. But when we started looking at the special stains, we could actually pick up the Helicobacter pylori, and we had to say, you know what, this is actually Helicobacter pylori related. So move away from that particular diagnosis. You know, if it's a bottom-heavy pattern, one will have to consider atrophic autoimmune metaplastic atrophic gastritis as a possible cause. If one sees the eosinophilic microabscesses, parasites need to be considered. And in this instance, one may have to cut multiple ribbons to actually identify the offending organism. What also helps with this patient that usually there is, if it's a eosinophilic, for example, gastritis, there's also involvement of the esophagus. There may be involvement of the parts of the duodenum as well. What is described is that usually as you go further down within the GIT tract, the amount of the eosinophils gets less and less, because apparently this is actually related to food allergy. So as you go down the GIT tract, the number of eosinophils may actually decrease. But every time one does this, has to make sure that a more easy to treat or more treatable causes are identified and excluded first. The other consideration with prominent eosinophils, including like a collagenous gastritis, drugs, post-radiation, and solid organ transplantation. So the clinical history again becomes very important in making sure that we are making the appropriate interpretation of the findings in the biopsy. So prominent eosinophilia, rather than making a call for eosinophilic gastritis, I rather prefer gastritis with prominent eosinophils. This is the list of possibilities if I'm not finding the underlying cause. And then if none, eosinophilic gastritis can be considered as the etiology, rather than going straight into eosinophilic gastritis. Then we start looking at the various food that the patient might be reacting to, when actually the patient is just on drugs, or that needs to be looked at, for example. So looking at this example, one can see the prominence of the eosinophils. Actually, when you look at this, it just looks, you can appreciate the eosinophils with their appearance there in the background as the possible cause. And there are various numbers that are given in some, like how many eosinophils one should have per high power field. I think although there are those definitions, it also remains arbitrary. And some they will argue for various numbers from 30, some they want more than 50. So we always do our reference checks as well. And then some they argue that in different population groups, there's actually differences in how much eosinophils one is allowed to have. So it's kind of like open to interpretation as well. So it's being a diagnosis that we make with exclusion, but with the definitions, there are debates about what defines it. So once we make a diagnosis of eosinophilic gastritis, it's because we have excluded all other possible causes, and then we are now suggesting a food allergy of some sort. So then food allergy is a very difficult thing to treat. So yeah, we should always be wary about that diagnosis, because it disrupts the family's life essentially. In the instances of post-radiation eosinophilic gastritis, we can see the lamina propria here with some eosinophils in the background. But what you are also seeing are these actually atypical fibroblasts. There's also some background fibrosis that is present, and there is some atypia of the epithelial cells. So in the appropriate context, even if the clinical history is not there, I will be calling the surgeon or gastroenterologist. Has this patient been exposed to radiotherapy? What I might end up doing might also do a cytomegalovirus stain just to make sure that these are not viral inclusions of cytomegalovirus, and I'm not missing that before I make that call. Or if the history is already there, you're like, okay, it's consistent with that, and then you save the patient additional investigations, or even you save the time of delaying the report because you're doing unnecessary investigations. Iron pill gastritis. So this is actually the effects of the iron pills that a patient may be taking. You can see, so this patient may actually experience dyspepsia, gastric pain, gastric ulceration, even gastric perforation. With what one will see would be the deposition of this crystalline material in the surface of the gastric mucosa. It may also involve the gastric crypts. And then when you do the special stains, which is the Prussian blue, will just confirm the deposition of iron. And these patients need to be off iron. If they really need the iron, I think the liquid iron is a recommendation to use. With the iron deposition in the stomach, there are virus differential, but when it's on the surface like this, the diagnosis is iron pill gastritis without arguments. Other consideration is about where the iron is being deposited, which we are not looking at today. Lymphocytic gastritis. So the lymphocytic gastritis is defined as when one sees an increase in intraepithelial lymphocytes involving the upper epithelium, and it's associated with the loss of the mucin, on its own, it's a non-specific finding. Importantly, one has to identify the underlying cause. The causes, one, and the first to consider is Helicobacter pylori infection. So, excuse me, with a Helicobacter pylori infection, the organisms, they tend to be very sparse, so one may actually miss them. Again, here it becomes important to do your immunoperoxidase stain for Helicobacter pylori so that you can identify those very sparse microorganisms, because even if you just find one, then you can give that as the underlying cause. Then the other possibility that needs to be considered after excluding that is the possibility of celiac disease, the possibility of various drugs from the PPIs and your NSAIDs. And remember, a lot of patients are on NSAIDs, a lot of patients are on PPIs. So essentially, this finding may actually be seen a lot more often as a function of drugs, but also Helicobacter pylori. With a celiac disease, one will have to consider that the patient should also have other clinical symptoms that are part of that, than to just make that call. And if there is an underlying cause, like Helicobacter pylori, then the diagnosis should be Helicobacter pylori gastritis rather than calling it lymphocytic gastritis, because it may introduce a confusion. And if the Helicobacter pylori immunoperoxidase stain has not been done, then one has to consider that maybe I'm just not seeing these organisms because they are sparse. Remember, we make that diagnosis because we have seen the organisms. And remember that not seeing the organisms does not always mean that they are not there. It might just be that they are just so few that it is not easy for us to see them. I'll give an example of a granulomatous inflammation, whereby the literature says that when we see about one acid-fast bacilli, there are usually about a few thousand that you are not seeing on the slide. So essentially, the fact that you are not seeing things may not necessarily always mean, hence you are using virus techniques, the reaction pattern, the ancillary tests. But once you have your immunoperoxidase stain, it kind of like helps you as well, because it can pick up very sparse. Sometimes two Helicobacter pylori, you'll pick it up easily with your immunoperoxidase stain. But again, it's about the levels as well of where you're cutting the plane. Is it there in that plane where you have cut your section? So there are other issues that we have to consider. So looking at this particular image, you can see the lamina propria with numerous mononuclear cells and the intraepithelial lymphocytes as well, which one can also appreciate here as in the lymphocytic gastritis. So the most common cause in these cases will be Helicobacter pylori, and the Helicobacter pylori immunoperoxidase is very important due to sparsity of the organisms. And the other conditions need to be looked at, like celiac disease and drugs. So clinical history is of paramount importance in terms of making the appropriate call as well. Russell body gastritis. This is a very rare diagnosis that we may have. So for these patients, the biopsy shows accumulation of plasma cells which contain intracytoplasmic eosinophilic globules, which are actually, those are immunoglobulins. The most common offender in these instances is usually the Helicobacter pylori infection. So it's just another phase. So one can be fancy and call it Russell body gastritis, but one can just go normally and say, one can be fancy Russell body gastritis secondary to a Helicobacter pylori infection, or one can just be simple and say Helicobacter pylori associated gastritis to not introduce the first. But when one sees it, one has to consider various things. So when you look at these images here, you can see these plasma cells, which are rich in these eosinophilic globules, which are actually the plasma cells. If you remember earlier, we spoke about these reactive germinal centers, which are pathognomic of the Helicobacter pylori infection in the stomach. So you can see it here. And in these instances, the number of Helicobacter pylori may vary from sparse to more easy to identify. Helicobacter pylori then is off value in this instance if you're not seeing the organism. But if one sees the reactive germinal center, personally, I would be inclined to say it's most probably related to Helicobacter pylori infection, although I cannot see the actual organism. So eradication therapy is important in these patients. Rebiopsy may or may not be necessary. The consideration that one has to make sure they are not overcalling is a diffuse adenocarcinoma, as a mimica or a plasmacytoma or a mold lymphoma, which may also have a Russell bodies in it as well. So these are areas that we generally would be concerned to make sure we are not missing. I think I'm just within time. So my conclusion is that gastric biopsy itself on us is actually a biopsy that we find very often. So essentially, any doctor would essentially get this will get this biopsy, and an understanding with a systematic approach can help us to get to a diagnosis with minimal cost to the patient. We need that clinical history. The evolving reporting guidelines, especially the OLGA and the OLGIM staging system of atrophy, I think these not so new kids on the block, but they are the new kids on the block that we should look out for, and probably maybe also use it to stratify our patients who might be at risk of actually developing the gastric cancer. And then a lot of other cases of chronic gastritis, especially the inactive one, may not have a histologically identifiable cause, or the causes may be unknown. But wherever the pattern is characteristic, I think we should be able to give the appropriate guidance. We think it is H. pylori related or it is not. That is the possibility. And please remember, Helicobacter pylori is the most common cause of gastritis, at least in the community. Last, as doctors, we refer patients to the surgeon, the physician, or we refer back to the GP. You know, those are doctor-doctor consultations. I think also sending through a gastric biopsy or any biopsy is essentially a request for a consultation to your colleague, and for us to be able to give the correct diagnosis, we need to know what is the question that the colleague wants us to answer. And for that, the clinical history becomes very important. And even more importantly, it makes us be able to give a cost-effective, high-quality report. So without the clinical context, we are always fishing for anything and everything, you know. So we do need that information to be provided to us. Autoimmune metaplastic atrophic gastritis, autoimmune pangastritis, and autoimmune enteropathy have important clinical associations that I believe we need to be aware of, and make sure that when we get such diagnosis, we do the appropriate follow-up. I'm just gonna do this little vignette, share this vignette with you. 48-year-old, this is not a real patient, by the way. 48-year-old lean female working professional visited the general practitioner with a complaint of fatigue, malaise, and gastritis. In addition, she had a history of diabetes mellitus. She was referred to a gastroenterologist for endoscopic guided biopsy, which showed bottom-heavy inflammation in the corpus, so that body. In addition, intestinal metaplasia was present. The antrum, lesser and greater curvature, including insula angularis, showed features of mild chronic gastritis only. So what would you consider to be the most likely diagnosis in this particular patient? Maybe just to rehash what we have in the biopsy, we have bottom-heavy inflammation involving the body corpus. There is also intestinal metaplasia that is present. There is minimal inflammation in the antrum. I'm not sure if you can share your thoughts on the answer, but I think I'm not seeing anything. So in this particular case, so what would mainly have this bottom-heavy chronic inflammation that is predominantly in the corpus? At least we can say here we are looking at the autoimmune gastritis, but in the stomach, in the body, this is mostly the autoimmune metaplastic atrophic gastritis. That should be the most likely diagnosis. And then when for the additional investigations were undertaken, what would have been the expected results? Anti-intrinsic effects antibodies, we expect those to actually be positive. Anti-parietal cell antibodies, expected to be positive. Vitamin B12, expect that to be low. Serum iron, also expect that to be low. So this actually would explain the history of this patient experiencing fatigue as well as malaise. So meaning that they're actually having anemia as well. These are just some of my selected references. That is the end of my talk. I'd like to thank all of you for listening and for attending and sparing your afternoon. And I hope this has been meaningful and helpful. Thank you.